Great. So I think we can start. Dr. Felipe, are you ready?
Yep.
Great. So today is Dr. Felipe's presentation. Dr. Felipe is a fellow of the Division of General Surgery and Trauma at the University of São Paulo. And he's going to present us a case, a trauma case. It's very interesting. I think we're going to enjoy it a lot. So feel free to start whenever you want.
So good morning. We have a 60-year-old male. He had a fall from height, 4 meters approximately. He was brought by a ground advanced ambulance that in Brazil means there's a doctor in it. The total transport and infield time was 60 minutes. And what they did on the field, they saw they had a trauma on the left side. They did a left needle thoracostomy, and they gave half a liter of Hinger for this patient. On the scene, his heart rate was 80, his Glasgow was 12, and his systolic BP was 130. When this patient arrived to us, he had a patent airway, normal breath sounds, symmetrical breath sounds. He was now hypotensive. His BP was 60 by 40. His heart rate was 135, and he had a tender abdomen. His Glasgow now was 14, and he had facial bruises, especially on the left side of the face. A fast examination was performed, and it was very positive on the right upper quadrant. And it was negative on pulmonary windows or on the other abdominal window. This is his point of care labs. He is acidotic. Their diminished basic excess. His lactate is very elevated also. On the trauma bay, the MTP was activated. But after this patient received just 2 blood packs that we have on the bay, 1 plasma and 1 liter of Hinger, now his heart rate was 95, and his systolic blood pressure went to 100. And he also received tranexamic acid. So I guess the first thing now we could consider is taking this patient or to the CT or to the OR.
Wow, let the games begin. Dr. Untracht, what do you want to comment in this case?
Yes. So in this case, the patient is either transiently stable with blood, or he is stable with blood. And if he's stable after receiving blood, he can have a CAT scan. But why? You would all you would find out is the source of bleeding, which is likely to be the spleen or some other solid organ. And you can't do anything about it in the CT scan. If you're going to go to a hybrid room or to IR, okay. And you said the FAST was negative in the pulmonary windows and the other abdominal windows. So in other words, he had no sliding, and he had sliding on both sides. He had no pleural effusions or hemothoraces. And you should have been able to see the spleen well. So you're saying that you imaged the spleen and it was totally normal. Is that what you're saying?
They didn't find any liquid around the spleen, but the person that did the FAST examination was our third-year resident. So he just didn't see liquid. He couldn't see anything else on the FAST. Okay,
well, he needs to practice on his colleagues about imaging the spleen, or on himself with the phased array probe and the curvilinear probe, but should be able to see the spleen. But anyway, regardless, he was hypotensive, as a floridly positive FAST below in Marsden's pouch and in the between the diaphragm and the liver. So and he's had high lactate level, and the thing is, taking him to CT scan won't fix anything. So if the CT scan you could fix something, fine. But so I would prefer to take him to the operating room.
Excellent. Dr. Chiodetis, so what are your thoughts on that? Would you rather take this patient to the OR and fix anything that is going on in the belly, and then maybe take him to a whole body CT scan, for example, or would you try to get this patient stable enough to go to the CT scan beforehand? And if you prefer the CT scan, what are you expecting to see? What is going to change your management if you do the CT scan first?
Well, I think the patient is very sick, and even though that he kind of normalized a little his blood, his vitals with only blood and plasma, I won't take this patient to the CT. I think he's very, and we need to go to the OR very fast and try to control. I think it might be the spleen that is bleeding, or he might have a mesenteric tear that is actively bleeding. So once, the other thing that I will put a chest tube if he already was decompressed with a needle in the field. And make sure also that you have a chest x-ray and a pelvis x-ray to make sure that he does not have also a pelvic fracture. Because of the mechanism, he might have to. But I think that 60 years old, this patient is very sick and needs something done very, very fast.
Excellent, thank you. Dr. Supa, do you think that the age of the patient in this case would make a difference between choosing the CT scan or immediately OR?
I think he's old and he doesn't have much physiologic reserve. So I agree with Dr. Untrat and Marta to take him to the OR to stop the bleeding first. Anyway, CT scan may give you some information that can be helpful. For example, you may find extravasation in the liver or in the pelvis that may be deal with interventional radiologists, maybe can be managed by embolization. Or you can see other associated injury like aortic injury or bleeding in the brain. But anyway, the first priority in this patient is to stop the bleeding in the belly. So I think OR is the way to go for this patient. And if you have hybrid room available in your hospital, I think this is the place that he can go to. Because if you find bleeding, a bad liver injury or bleeding in the pelvis, you can, after packing, you can call IR to deal with those things immediately. Thank you very much.
Excellent, thank you. So it seems that it's 3-1 in favor to the OR. So if anyone in the audience is in favor of the CT scan first, please raise your hand and give us your comment. If not, we're going to proceed with the presentation with to see what happened with Dr. Felipe's patient. Okay, it seems everyone wants to go to the OR, so I think you can move on, Dr. Felipe.
Well, I guess we are on a minority here because we took this patient to the CD. So this patient was considered transiently stable. So the assistant team on the day decided to take this patient to the CT scan. So I will briefly show there are some fractures here on the temporal bone with some buried bone here, and there's a slight hematoma here with no midline shift. And there's some complex fractures here configuring a Lefort 1 fracture. On the thorax, there are multiple rib fractures here to the left, but they are all aligned fractures. And there's a minimum pneumothorax here. I don't know if you can see my mouse.
Yes, we can.
And just some slight aligned fractures to ribs, to third to the 10th rib on the left. So here we have an arterial phase. So we can see the hemoperitoneum here. There is this shattered spleen here with a lot of blushes here, a lot of active bleeding on the spleen. And there is a huge hematoma here. Alongside, we can see better on the portal face. There's a hematoma. There's not a lot of free liquid. Maybe that's why they couldn't see exactly free liquid here, and they thought they see the hematoma along with the spleen, and they couldn't see the liquid on the left side. Maybe that's why they couldn't see it. I don't know. I wasn't there on the day. But there is also a slight hematoma here on the pancreatic tail. So just to sum up, this patient had a pneumocranium. There is a frontal and temporal fractures on the cranium. There is an epidural hematoma, 1.2 centimeters, with a slight mass effect, with no midline shift. There's multiple facial fractures with a Lefort 1 fracture. There are fractures of 3 to the 10th left rib. There's a shattered spleen, and there's a hemoperitoneum. So this patient was taken to the OR.
Dr. Felipe, just before you go through the surgery, we have a question from Dr. Yoshiro Kobe. He's asking what factors would decide the patient was stable. So I think that he wants to know how did you come to the idea of taking this patient to the CT scan, or considering he was stable enough to go to the CT scan. I think that's what he's asking actually. So what were the factors and what were the parameters that you used or the team used to make sure he was stable enough to go to the CT scan? And then we have Dr. Untracht with his hand raised to make additional comments as well.
The patient had diminished his heart rate, had an elevated his blood pressure. He was considered stable enough by the assistant team on the day. I guess the biggest concern on the team of the day was about head trauma for this patient. They were afraid of just taking the patient to the OR to a laparotomy, then having to take the patient again to a head CT and then going back to the OR. So they considered that they could do it fastly enough that there wouldn't be no bad done for the patient. The patient was ultimately taken to the OR, I guess 90 minutes after his admission. The CT added around 30 minutes to this process.
Dr. Untracht, do you wanna add any comments? Did you raise your hand?
Yes, you mentioned that he was considered transiently stable or a partial or a transient responder to the fluid. So what were his vital signs from the time you decided to take him to the CT and during the CT till he got to the OR?
This patient, when he was took to the CT, he had a heart rate of 95 and a systolic blood pressure of 100. He stayed during the CT with this signs here.
Okay, and then also based on the CT that you showed, the big hematoma in the spleen would have been visible on an ultrasound. Something that it just for follow up for your residents, and it's easy to teach that because you don't have to wait for another patient to come in. Just image each other and use the phased array probe if you can't see through the ribs. So and that'll show you the parenchyma of the spleen. But I agree, there was no blood around the spleen between in the spleno-renal pouch or between the spleen and the diaphragm. So that part was correct.
Yeah, we also advocate for these cases that the residents, after the CT scan, when possible, of course not in this case, but in the other cases, he goes back with the ultrasound to rescan the patient, make sure he's seeing all the abnormalities. But I would add in this case that sometimes the blood in the ultrasound is not anechoic, so we are very used to see that black image that we we interpret as fluid around any organs. But sometimes, and I think we already discussed one case here in the PTS meeting from Ryder Trauma Center, and we actually had a very similar case a few weeks before this presentation. And the blood between the liver and the kidney, or the spleen and the kidney, sometimes is a little hyperechoic, and it sometimes may misguide the surgeon or the physician in what he's seen actually is not blood. He thinks that it's a structure, or the spleen, or the liver, but actually it's kind of a clotted blood in this area, and it makes the image more hyperechoic. So maybe this also misguided him. So I wanted to ask the panelists a quick question. What do you do? So it seems that the most they were afraid of having a head injury and not identifying this before the surgery. So that's why they took the patient to the CT scan, because I think that we all agree that there was enough blood in the ultrasound to grant this patient a ticket to the OR. But if everyone is like afraid of having a head injury, what do you think it might be something different to do in these cases? If the patient is not stable enough to get a CT scan, so how do you manage this patient who is very unstable and may have a head injury? Would you do anything different? Would you consider any type of image different from what we are discussing here? Dr. Untracht? Dr. Untracht?
Yeah, so at the scene, there was no report whether there was loss of consciousness. I guess by the time the doctor got there with the ambulance, the patient was awake, so he might have lost consciousness. So at most, he may have had a transient loss of consciousness, and then he had a temporal fracture, so that could result in an epidural hematoma, which would give him a lucid interval, and then he could develop a shift, and a blown pupil late during the operation. So theoretically, that's possible. But if he comes in with a Glasgow Coma scale of 12, I think that is adequate to forego a CT scan if the patient is hypotensive. But now in this case, he got fluids, he responded, he remained relatively stable through the CT. So it's okay, but you have to do that with caution. If the patient remained hypotensive, I wouldn't worry about the head. The most important thing you can do for somebody with head trauma is stop the bleeding in the abdomen to keep the cerebral perfusion normal. So I think you have to tread cautiously and go primarily based on the condition of the patient overall before deciding for CT.
Excellent. Dr. Chiodetis, do you use anything different in the trauma bay, in the trauma center that you work in? Maybe ultrasound or the optic nerve sheath diameter or something like something similar?
What we usually do here is that we take the patient to the OR and we monitor the pupils. And after we finish and the patient is kind of stable, then we go to the CT with the patient intubated and vitals secure and everything. We take them to the CT scan. And I was gonna say that whenever you have any fracture in the face, the possibilities of having a head injury also is something that you have to remember every time. And I think the best approach for this type of patient is to stop the bleed, make the vitals normal. And we know already that every episode of hypotension makes the mortality for the head trauma 10% up. So we need to keep on stopping the bleed first, and then taking the patient to whatever measure we need to do with the head.
Great, thank you. And there's also increased mortality when you take too long to get the patient to the OR, right? Dr. Supa, to summarize this discussion, do you use anything different in your trauma center for neurologic evaluation in the point of care and the trauma bay?
I agree with both Dr. Untrat and Martha. We should stop the bleeding first because that will benefit the patient with severe head injury the most. And I think the only scenario that I would try to get the CT scan before OR in the patient with bleeding at the abdomen is the patient has obvious sign of brain herniation, like unequal pupil or M3, M2 motor response. In that case, and if the patient responded to the initial fluid resuscitation, I may try to get a quick CT scan of the brain only, and then go to the OR immediately. Unfortunately, this type of patient, even if we have a hematoma in the brain, a neurosurgeon would not try to do the operation at the same time with us, because at that time the patient was hypotensive and very coagulopathic. So they wouldn't attempt to do the craniotomy when the patient is not hemodynamically stable and when the patient is coagulopathic, hypothermic. So even if you get the CT scan, it's difficult to do both procedures at the same time. So I agree with Dr. Untrat and Martha to stop the bleeding, stabilize the patient first, and then get the quick CT scan. Unless you have a portable CT scan in your ICU or in your hybrid room, so the problem is not the big deal, because you can easily get the CT scan quickly afterwards. Thank you.
Excellent, very interesting discussion. We sometimes in our trauma bay where Dr. Felipe and I work, we sometimes use optic nerve sheath diameter from using ultrasound in these unstable patients, at least to get a clue if the patient has intracranial hypertension. But not everyone in the trauma bay is used to do this evaluation, so it's not something that we do in a very standardized way. It depends which attending is on call that day to make sure this is going to happen. I wanted to ask Dr. Steven Epstein, I don't know if he's able to open his microphone to get his input, because it's very interesting what Dr. Supa said. So sometimes you have the image of the brain and you need to coordinate this with the neurosurgery team. And sometimes you do have like a very important feature or a very important tip that you have something in the brain, but the neurosurgeon doesn't want to open it without a CT scan. And Dr. Steven Epstein said that maybe you can have the neurosurgeon to do a craniotomy if the patient blows a pupil on the table. So I don't know if you are available, Dr. Steven, but if you could open your mic and comment on that, I think it would be really interesting. Okay, I don't think he's able to open his microphone, but it's a very interesting discussion. No problem, Dr. Steven. Thank you. So I think we can go on, and in the next steps of the presentation, I'm going to open a question from Dr. Kobe about the management of a specific kind of trauma. So I think you can move on, Dr. Felipe.
So this patient went to the OR. Why is it more here? So this patient went to the OR. For some reason, it's small here, but there was a lot of blood in the abdominal cavity. A self-saver device, auto-transfusion device was used. The spleen was identified. And there was a multiple lacerations, huge laceration on the spleen. Beneath here, there is the pancreas, the pancreatic tail with the splenic hilum. There's that hematoma we saw. And now they're going to perform the splenectomy. As there was this hematoma here, the surgeon decided to do some suture on the pancreatic tail to avoid a pancreatic fistula. Here's the fragments of the spleen that were removed from the abdominal cavity. So it was performed a splenectomy with closed suction drainage, and neurosurgery team also entered after to do a temporal fracture treatment. On the OR, this patient received 3 blood packs, 3 plasma, 1 platelet, 2.5 liters of Hinger. It was auto transfused almost 1.5 liters of blood, 2 grams of fibrinogen, and he went out of the room with 0.35 micrograms per kilogram per minute of norepinephrine, and 10 cc's per hour of vasopressin. And this was his vital signs. When he arrived on the room, he was slightly tachycardic and hypotensive, and it was later corrected. And this is his labs after the surgery. Before the surgery and after the surgery. He was still acidotic. His lactate cleared a little bit. His base excess remained basically the same.
I'll just make a quick stop here, Dr. Felipe. Unfortunately, we don't have Dr. Varon today. He sometimes comments on the anesthesiologist part of this cases, and it's very interesting. But I think that there are some things that are interesting to discuss here. I think I would start with the management of the risk of having a pancreatic fistula that you told us that the surgeon did some sutures in what he thought it was like a hematoma, and he was afraid of having some of the pancreatic tail there, risking having a pancreatic fistula. So I would ask Dr. Marta Chiodetis, what do you think of this strategy to reduce the postoperative pancreatic leaks? Would you do anything different? Would you do this? I have never done this, so that's why I'm asking you.
I think we should not touch the pancreas unless we see something that is evidently bleeding or something coming out from there. You have to explore all the hematoma, yes, of course, but if you don't see anything bleeding, you just leave a drain and place it there. I don't think there is any strategy that helps you reduce the possibilities of having a pancreatic fistula in this type of patients.
Great, thank you. I want to ask a question for Dr. Supa as well, and I'm going to include a question from Dr. Kobe in this question. So Dr. Kobe was asking about the coagulopathy management of these patients who sustain both truncal and head trauma. So we know that coming from the literature, we have a higher risk of coagulopathy in this patient. So would you do anything specific trying to address this issue? And on top of that, I wanted to ask you, what do you think about these labs that are showing in the screen? Because it seems that post-operatively, the hemoglobin went up, but the other parameters from the microcirculatory hemodynamics, they got worse actually. So what do you think about that? What could be done differently?
For the pancreatic injury, I think I agree with Martha. If possible, we try not to touch the pancreas. But if you have to resect the injured pancreas, I think there is no standard way to close the pancreatic stump. Whatever you do, you will get the leakage around 20 to 30%. So the most important thing is if you cut the pancreas, try to close the stump and leave the drain. And then you get like a control pancreatic fistula that usually will close spontaneously. And the second question, for his lab, I think he may be still under resuscitated because his microcirculation is not quite good. He has a bed excess of -10. And in the patient with hemorrhagic shock, I usually don't use norepinephrine. to raise the blood pressure, because that will constrict the peripheral blood vessel and may even impair the peripheral tissue perfusion. So you may get the better number on the blood pressure, but the microcirculation may be worsened. And to correct coagulopathy in this patient, I think if you have conventional labs, that's okay too. You try to keep the platelet above 100,000, and try to normalize PT, PTT, and if the fibrinogen is low, you give a cryoprecipitate or fibrinogen concentration. And I usually use the tranexamic acid liberally. But if you have a viscoelastogram, that would help you specifically with a point of care transfusion. You will know that the patient needs which component of blood, and you can give that accordingly to the result of the thromboelastogram. Thank you.
Great. Dr. Untracht, any additional comments regarding the pancreatic the hematoma suture, and the coagulopathy of this patients? And also I wanted to ask everyone in the audience to put in the chat if you have viscoelastic tests in your trauma center to use in these patients, even post-operatively, or not. So if you please want to comment in the chat, and we can enhance the discussion. Dr. Untracht.
Yeah, so in the slide before, Dr. Kfouri called this a damage control surgery. So there wouldn't be any place to do any definitive treatment for the pancreas. You've left a drain, you've taken out the spleen, so you've controlled the damage, and it's, rather than making more damage, just wait and see. And then you can, if there's a pancreatic leak and the patient doesn't need to go back and be re-explored, you can just treat it like you would any pancreatic leak, wait for a controlled fistula, and do a fistulogram and slide inch the drain out eventually. If he did need something more definitive, then during a later procedure, you can do a partial resection of part of the tail of the pancreas. But I wouldn't do anything now. It's a little bit meddlesome to really interfere with something to prevent the complication that hasn't occurred yet, that would be easily manageable. As far as the coagulopathy, I didn't see any, maybe I missed it, I didn't see any labs about about coagulation, but the team did everything right as far as blood products. They gave TXA on admission, and he got fibrinogen and platelets and plasma. So they did everything right. And I agree, it's good to have the thromboelastogram. We don't have it here. I don't know if it's too expensive or whatever, but that really is very good to tell you exactly what you need to do. It gives you complete information, as opposed to, platelet count, which doesn't tell you anything about platelet function. And, but they did everything they could possibly have done for a coagulopathy if it existed. About the labs, the only thing that seems a little bit worse is the pH. And the other lab, the PCR3, I assume you mean bicarbonate level, that's better. The PCO2 is okay, and the lactate's going in the right direction. The base excess are improved a little bit, and Dr. Suba's point about norepinephrine, especially for a 60-year-old man that might have underlying coronary disease, it's that's probably best avoided. That's it. At best, it's an internal tourniquet. Like any tourniquet, it just buys you a little time. So he should be able to come off the norepinephrine. The other thing is, you showed the anesthesiologist graphs, and you mentioned that when the patient entered the OR, he was tachycardic and hypotensive. So if so, then really the CT scan didn't really change your immediate treatment. And that's something overall, it's a good case to review with the team, showing them this video, the video of this conference, because there are a lot of learning points here. But and it's good that you're discussing this way. So it's really, it's very educational.
Yeah, it seems that the CT scan didn't bring any additional valuable information that would change management, right? So maybe this patient would have been best going to the OR directly. That's interesting. And just wanted to point out that it's a very interesting discussion, the vasoactive drug administration, because sometimes people tend to get a little bit confused with when to do it, because it's really a nice strategy for a damage control resuscitation, but maybe when you have the damage controlled, I think that you need to put a little more weight in the transfusion and putting some volume. So maybe it's a very fine line between stopping the vasoactive drug and starting the transfusion. And also we need to address the shock component of this trauma. It's not just hypovolemic, but in some situations this can escalate to a shock, like an inflammatory response, and sometimes this needs to be managed using the vasoactive drugs. But it's a very difficult situation. I agree. So I think that Dr. Philippe, you can move on.
So this patient was activated on the second postoperative day. On the third day, MLS was searched on the drain, and it resulted in a very high MLS. Our reference level here is around 300. We got 20 times that. On the 8th day, he did a control head CT. The neurosurgical team asked for it. They find a subdural hygroma, and they operated on it on the 9th, on the next day. And on the day after that, he did a new control CT. Let me just show the CT. He has this collection here, but it was well contemplated by the abdominal drains. He also had subsegmental thrombus here to the right. And here the control CT of the head. Still with a slight collection here. So the platelets of this patients steadily increased. They are now around 1 million. And the drain output is started high. Actually have a few more days here that the drain is very low. His output is very low. It's around 50 to 40 cc's a day. The patient is still with us. He was discharged from the ICU on the 12th day. His Glasgow is now 15. He's eating per mouth. And we're just received this patient on the yard. And we're going to see what we're going to do, how long we're going to have to wait about this pancreatic fistula. His injury severity score was 29. His RTS was 6.3. And his probability of survival was calculated around 63%.
Great.
So
yeah,
I have a paper from Dr. Ordonis. I don't know if we want to present it or.
Yeah, I think we can move on. Just present it, and I will ask a couple of questions to the panelists again.
So just to further the discussion, actually, sorry, I want to thank Dr. Lenira and Dr. Ogawa for providing us with this case. So just for further discussion here about the CT scan on unstable patients, we got a paper from Dr. Ordonis from Cali University in Colombia. It's a retrospective study. He could gather around 171 patients. 80 patients went to the CT scan before, and 91 patients went to the OR without any scan before it. His inclusion criteria was SBP of less than 100, heart rate more than 100, or 4 packed blood on the trauma bay. Actually, it's not on the paper, but it's on the comments on the presentation on the WTA, that only 20% of the patients only had a heart rate of 100, so more than 100. So most of the patients or received a lot of blood baths or had a high systolic blood pressure. What is interesting on this patient, on this group, that you can notice that most of the patients that went to the CT was patients probably like our patient. It was more blunt trauma, had a slightly higher ISS than the operating group. Their Glasgow was a little bit lower, so they were suspecting probably of head trauma on these patients. And they had more head injuries than the operating room first patients. Notice that was no visible difference in transfused units, but there was a difference in time to the hemostatic treatment. It was almost double the time here on the CT group, 60 minutes against 30 minutes on the operating room group. And there was no difference on fast examinations. Like our patient, there were patients with a positive fast exam. And what they say on the paper and on the Congress is that maybe they could see patients that only had like a liver laceration from, or the head that was unstable and not necessarily needed operating room. And the big thing about this paper is that they couldn't see any difference in mortality in both groups, between the operating room group and the CT group. And also what they are telling us that they say they avoided surgery in about 50% of the patients on the CT group. So that's their big claim. Of course, that's a retrospective study. There is a big selection bias going on here. And there's a lot of other problems that I guess, I don't know if you guys have seen this study, but mainly about selection bias. Maybe these patients were not that hypotensive and we are putting all the patients on the same bag, but it puts a slightly dent on the CT unstable patients dogma, at least on my opinion. But of course, it should be interpreted with great caution. Thank you.
Great, thanks a lot. So I'm going to ask for additional comments from the panelists, and then I have a quick question for the three of them as well. So Dr. Untrak, do you wanna make additional comments or comment on the paper that was presented?
Yeah, about that paper. So there were 14 and 16 patients in the two groups that had a positive FAST. So the issue is whether that paper has any external validity to this case. And for all the caveats that you mentioned, you know, the one study like that, it's, you know, I wouldn't, you know, I wouldn't rely on that. You can bring it, have your lawyer bring it into court to confuse the jury, you know, and find reasonable doubt. But, you know, in a case where you have a hypotensive patient who got to the OR hypotensive and he had a fluidly positive FAST, look, you saved him, he did well, you know, but I think this is the case where you want to review, go over with a fine-tooth comb, learn as much as you can in a patient that did well, you know, but what about next time? So learn, you know, how to practice more with the ultrasound probe, especially in the, you know, the starting second year residence and up, you know, looking at the spleen, seeing what it looks like, getting an image, and you know, and the rationale for going to the OR first if it didn't change your management. So, you know, I think it's worthy of discussion. I think you can get a copy of the recording of this conference and then review it with the whole team. So I wonder, were any of the senior attendings there, or just the fellow and the residents manage the case themselves, I guess? Is that right?
Dr. Felipe, you are muted.
All right. No, there were senior attendants there.
Okay, and look, and it depends on your, you know, like in University of Miami, the CT is right there. They'll take the patient in. So your situation might be the same. You know, your situation might be the exception to the rule. But you say it delayed the operation by what, 30 minutes, and the patient went in hypotensive to the operating room. So, you know, and the patient did fine, but in retrospect, it's like, okay, well, what about next time? You know, and there's a great case for learning. These cases where, you know, the patient did well, it's not too difficult to criticize some of the decisions you made, but the case was handled well, and, you know, and a couple of things for learning, and that's the whole purpose of these conferences. But good job.
Yeah, I really enjoyed your talk about the lawyer. It was really interesting because it's the probable cause. It's interesting to see like that. But I agree with you, Dr. Untracht, and I really I think that we should strive to make the process better, right? Not only the outcome. We are very used to look only at the outcome, but we need to look more into the process. What can we do better next time? So not only if the patient is still alive or not, but what can we do better next time to make sure we are having the best outcomes possible, right? Dr. Chiodetis,
before you move on, if I can just say, you know, in America, and I suppose you probably use the same paradigm there, but for continuous quality improvement, you're talking about structure, process, and outcome. For structure, it's, you know, where your CT scan is in the building and what staff you have, and whether you have an ultrasound, whether the staff can do it. And then the process is what you're talking about, and those two things affect the outcome. So that's the way all of these cases need to be analyzed, you know, in the end, especially when it's internal, you know, when you're striving to do your best. But it's a good point.
Yeah, great. Thank you. Dr. Chiodetis, do you want to make any additional comments on the case or on the paper?
I just want to point out that you have to adjust the way you do things. That's the process. You have to adjust to what you have available. So, for example, I have limited blood bank resources. So I need to make sure that our patients gets the bleeding stopped fast, because I do not have the luxury to spend 20 units of packed blood red cells in one patient. Okay, so you have to adjust your treatment to the resources that you have available. And that's something that is very important because this is something that is being heard in many places, and we have to make sure that we take care of also of the resources that every place have, because we have to do the best that we can, but with the little or much that we have. So that's the only thing that I want to say.
Great, excellent point. I think I agree completely. Dr. Supa, any additional comments on the case or regarding the paper?
I have no additional comment. I just want to thank Dr. Felipe for presenting this case, and very nice to hear Martha's voice again. Thank you.
Thanks. I want to make just a final question for the panelists. So it seems that this patient, he developed pulmonary embolism. How do you manage the prophylactic anticoagulation of these patients in the post-operative period? Because we have a polytrauma patient with a lot of issues, and you at the same time you need to provide him with some form of anticoagulation prophylaxis. There's a very interesting study that was published, I think, in the last year, like in the end of the year. And if I'm not mistaken, it's from a group from Texas, and they were studying the use of aspirin as a prophylaxis for pulmonary embolism. I'm sorry, for DVT, and it seems that they found very nice and very interesting results. So I don't know. I wanted to ask you, how do you manage the prophylaxis for these patients in the post-operative period? When do you give the prophylaxis? Which drug do you use? So, Dr. Untracht, let's start with you.
Yeah, so when the patient gets stable and in the ICU, we check the sonograms of the legs, the venous sonogram of the legs to rule out DVT. If they rule out, then you can give them sequential compression stockings and or low molecular weight heparin early on. And aspirin, I'm not so sure about, because once you give it, then you can stop it, but it takes 2 days for the platelets, for unaffected platelets to reappear in the circulation. So, and that would be, I guess you can give it rectally, but I don't know how the studies where they use it, they give it orally or how they administer it. But I would stick with low molecular weight heparin and the Kendall boots. In this case, that was really an incidental finding that was clinically insignificant. So it wasn't. I'm sure that they didn't need to do anything about that. I don't think you sent this patient home on Coumadin or Eliquis, did you? You didn't provide any long-term anticoagulation, I assume.
Oh yeah, the patient is still in the hospital, so it's
Okay.
a very recent case. So we didn't get to there yet. Okay, excellent.
But the patient is not anticoagulated now, I assume, right? Or just on prophylactic, just on Lovenox?
His prophylactic low weight heparin seems the second postoperative day.
No.
Great. Excellent, thank you. Dr. Chiodetis, any additional comments in the prophylaxis?
We start prophylaxis 48 hours after the patient coagulopathy was corrected. So that's kind of, make sure that there is no more bleeding in the brain with a repeat CT, and then that you have everything under control in your chest and abdomen. Also, I want to point out that there are some entities that I'm not sure how to call, but with a chest trauma, direct chest trauma, we can have some patient that presents with some thrombotic events since the beginning. So I'm not sure if that image that you show us is a result of a thrombus that formed after the trauma, or it was a consequence of the trauma, the direct trauma. So since it does not have any repercussion in the clinical stability of the patient, just only treated with a low molecular weight heparin if there is not any other contraindications.
Excellent, thank you. Yeah, very well pointed out, because there are some studies that are challenging the pathophysiology of the thrombus in the trauma setting, right? Instead of coming from the legs, for example, in the setting of a non-traumatic situation, there are some studies that are trying to figure out what is going on in the intravascular space of the trauma patient that would provide additional problems and higher risk for thrombosis and in situ thrombosis. That's the interesting part. Dr. Suparak, any additional comments on the prophylaxis?
I think that the study you mentioned, they did a randomized trial on the patient with extremity fractures, and they found that aspirin and lower weight heparin were not different in terms of DVT or PE, I guess. And that's interesting for me because the aspirin is cheap and is available throughout the world. So that's the good option. But like Dr. Untrach mentioned, if the patient takes aspirin and needs emergency surgery, you have to give platelets, because the platelet dysfunction will be will continue for a week with aspirin. And for this patient, I think if you stop the bleeding in the abdomen, the only limit, the only limiting point that will prevent the patient from receiving chemoprophylaxis is bleeding in the brain. So you have to discuss that with a neurosurgeon. If neurosurgeon allows, you can give the patient prophylaxis with heparin or low weight heparin, whatever you like. In my hospital, I found that in Thai population, in Thai trauma population, we don't have a high rate of VTE even without chemoprophylaxis. the VTE rate in my hospital in trauma unit is around 1 to 3% without heparin. So in my hospital, we do active surveillance. We do the weekly DVT screening with ultrasound. And if the patient has no DVT, we give the sequential compressive device to mechanically prevent the clot forming the legs. And that's it. Thank you very much.
Dr. Supa, I was interested in which protocol do you use to do the DVT scan? Which ultrasound protocol? What areas do you scan?
We use a vascular probe and check the clot in the groin, the thigh, and the popliteal fossa. The resident, the trauma team will perform that screening test. Anyway, we are not good enough to detect the distal or calf DVT. So the incident may be a little bit too low because we could not include the calf DVT. With limitation of our skill.
Okay, so you use the three site scan. Very interesting. There are a lot of papers about this, the surveillance and the use of the 3 site scanning of DVT. Well, very interesting. This discussion, I think it was really nice. I really enjoyed it. Just before we wrap things up, there are a lot of questions about the CME. So I'm not sure how to address them because I don't manage the CME for this meeting. So I think it would be probably better if you send an email to Liliana, or maybe trying to reach Kevin Miller, and he can explain this part of the CME for you guys. But I think that we are not having CMEs for each session anymore. I don't know. I'm not sure if that's correct. Dr. Utrecht, did you raise your hand?
Yeah, it's a particularly irksome issue because not only aren't the CMEs getting recorded, but they didn't add the American Board of Surgery into their list of reporting agencies. So even if they gave the credit, it wouldn't get reported to the American Board of Surgery, which is what matters. Liliana says that, she tells the CME office they're just not doing anything, so nothing she can do. So I think in this case, I was hoping that Antonio would be here. I think it's appropriate for him to take it up to the level above, maybe to the dean of the medical school, so he can get them to fix it, because it really affects the ability of the department to conduct CME. If they host a CME conference on anything, then it won't get reported to the American Board of Surgery. It affects the ability for the university to carry out its mission. So if you speak with Antonio Martos, I think I would raise that. You understand what the problem is, but I think we're all noticing that it's just not getting fixed, and it should be easy to fix the problem.
Hi, this is Kevin. I'll make sure that I reach out to Liliana and Antonio after this meeting. I just come on to monitor these meetings to make sure there's no hackers, or make sure everyone's behaving appropriately. I don't have anything to do with this CME or anything, but I will absolutely raise the red flag and send Dr. Martos an urgent email as soon as we're done.
Great. Thank you, Kevin. Thank you
Sure.
very much. Okay, everyone. Thank you very much for being here. I hope to see you next week, and have a good week, everyone.